from the American Academy of Pediatrics.
We all know the benefits of breastfeeding for both the baby and the lactating parent.
A new clinical report offers ways we can guide new parents living with HIV.
We want to approach these conversations like we would approach infant feeding conversations with any birth parent. We want to be open and offer both options if it's appropriate for that patient.
But first, it's July, and you know what that means.
These are things that are complicated, and I like to think about, the Swiss cheese model, where we hope that the holes in the system don't line up and lead to a bad outcome.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a research roundup from the journal Pediatrics.
Joanna, it's July. Summer at its most summery. How is it up in Philly?
Even though I'm farther north than you, it's really hot up here. And let's make it even hotter by announcing it's time for another First Up, where we burn through some fiery pediatrics articles.
Aye.
David, which of the editors of Pediatrics is joining us today to share the newest, biggest developments in pediatric literature?
Well, today, Joanna, we have Dr. Alex Kemper, Deputy Editor of Pediatrics. Alex, welcome back and happy summer.
Thank you. Glad to see you.
So, Alex, I am glad to see you too. But I have a question for you that has nothing to do with pediatrics, because your book recommendations for children were so good last time we had you on that we've decided you might just be a pop culture critic. So our question for you today, Alex, is what is your vote for Song of the Summer 2024? Is it Sabrina Carpenter's Espresso? Or because of the ongoing Eras tour, will it just be Taylor Swift's Cruel Summer again? Or you're my generation, Alex. It could also be Bananarama's 1983 Cruel Summer. Is that more your speed?
Well, I do have the 12-inch dance version of the Bananarama album. But I would say I think the Song of the Summer is going to be ABBA's Super Trooper.
Okay. Okay.
All right. We are of a certain age, Alex.
I'm of a certain age, plus a little bit earlier.
I like that. I'm gonna be putting ABBA up against Sabrina Carpenter to see who wins here.
I'm impressed, Alex. I was worried that maybe we were going to throw you with the musical question.
Oh, no.
Nailed it.
Believe me. How much time do we have to talk about 70s and 80s music?
Not that much.
That's a different podcast. Different podcast altogether.
Yeah, different podcast. And I think it's time that we segue from music into some of the latest articles. And one that caught my eye was outlining the rise in congenital syphilis, particularly in South Dakota. Can you tell us what is going on with these syphilis cases and why the state has been so affected by them?
For many great reasons, we've been preoccupied with other infections, right? We just went through the COVID pandemic. I think it's really easy to miss the fact that we're really having a major syphilis epidemic in this country. Between 2016 and 2020 nationally, there was about a 250% increase in cases of congenital syphilis. And I think it's really critically important that we remember that, because there's so many things that we can do to prevent the serious outcomes related to congenital syphilis. And I would point people to the AAP's Red Book, which really outlines very clearly what needs to be done. Congenital syphilis can be really challenging too, because babies can be born and be completely asymptomatic, but 2 years later show up with complications related to congenital syphilis. So we really, really need to all together think about this. So this month, we're publishing an article written by some individuals in South Dakota describing 3 cases of congenital syphilis that they had there. And Joanna, you're exactly right. The rates in syphilis have gone up nationally, but remarkably, they've gone up about 1,900% from 2017 to 2023 in South Dakota. And there are lots of reasons for that. South Dakota is a rural state, and there are issues with access to care. It has large Native American population that, due to issues related to social drivers of care, can sometimes not receive the kind of care that we would hope that all individuals and all newborns would get. I want to be clear that although the rate may be higher among individuals who are Native American, it doesn't have anything to do with being Native American per se. This is not a genetics issue, but it's related to the issues related to the social environment. And in this study, they described 3 cases, 2 of them where there was no prenatal care, and a 3rd case where the pregnant individual had some prenatal care while incarcerated. These 3 infants were all born with signs and symptoms of congenital syphilis and require prolonged stays in the NICU. Had these birthing parents received appropriate screening and treatment through their pregnancy, most of these cases are preventable. And so I'd like to talk about this article because it brings up issues of congenital syphilis, but I think it's important to remember that all pregnant individuals need to be screened at least once during their pregnancy and be screened more often if they're at high risk. And as stated clearly in the Red Book, infants should not be discharged from the newborn nursery or from the NICU without knowing about the syphilis serologies, that it's important that babies who likely have congenital syphilis receive adequate therapy, which includes 10 days of penicillin G. There's complications related to that, including some drug shortages that have happened in the past. These are things that are complicated. And I like to think about, the Swiss cheese model, where we hope that the holes in the system don't line up and lead to a bad outcome. And because of that, we all have a really important role in preventing congenital syphilis. So again, I think this is a really important case series to look at and think about in your own practice. What can you do to prevent congenital syphilis?
So, Alex, when we talk about holes in the system, one of those can be linguistic. Joanna and I both speak Spanish, and after 475 days of Duolingo, I'm getting to where I can actually talk to my Haitian Creole-speaking patients as well with a fair bit of understanding. But have I been wasting my time practicing languages when ChatGPT and Google Translate are right there on my phone? I mean, do we even need professional translators anymore?
Such a great question, and something that some of our trainees here were recently asking me about. I mean, these large language models, this AI stuff, is really, really amazing. I guess it's not for nothing that NVIDIA is one of the most highly valued companies in the world right now. They make those chips that run those large language models. I wish I actually understood how these things actually worked. But the question comes up, can you use machine translation to make better discharge instructions for patients and families? Can you do a better job with translation that way? And there was a study by Brewster and colleagues that came out of Boston Children's Hospital where they looked at 20 different standardized discharge instructions, and they had them professionally translated and then translated through the magic of Google Translate and ChatGPT 4.0. And they looked at things including the quality of the information, the fluency, kind of the way the words flowed, meaning whether there was a risk of clinical harm because there was a problem in there, and then the overall performance. Another real strength of this paper is they had 8 clinician evaluators who looked at the output of these translations to, essentially say which one was doing better across those different domains. And what was remarkable is that in general, the translations using the machine translation process did a really good job. It did not do as well with Haitian Creole. So don't give up your Duolingo Haitian Creole. But that kind of makes sense, right? Because these large language models are fed other information, fed other writing, and somehow magically it's able to piece things together. And there's a whole lot less written, I'm sure, in Haitian Creole that's been fed into these large language models. I have no doubt that these are going to continue to get better. But this study does, first of all, how science fiction-y is this, that you can really get such great translation out of these systems that are generally available and largely equivalent to professional translation. I have no doubt that things are going to get better. The question is, should we rely upon them now? Personally, I still am hesitant. Maybe I'm a Luddite about these things. So I feel like if I can get professional translation, that to me is still the best. But maybe I'm wrong. And this study certainly underscores the value of these other systems. And professional translation, right? It's expensive. It's hard to get. Oftentimes, you don't have the right individuals around. So would I use this today in the clinic? I would still need some convincing. But this study, I think, goes a long way to support the benefit.
And while AI is certainly the future of medicine, BMIs have been with us for a long time. Back on episode 144, we interviewed Dr. Sarah Armstrong about the AAP's new obesity clinical practice guidelines. I remember at the time there was some criticism both on media and social media about the guidelines' use of body mass index to screen for obesity. What is the latest research about using BMI as a screening tool?
So great question. And this is an issue that comes up all the time. So this month, we're publishing an article by David Friedman, who recently retired from the CDC, and colleagues on the screening accuracy of BMI for adiposity among 8 to 19-year-olds. And I think as we drill into this study, one thing that's really important to recognize is that BMI is a screening test. And oftentimes, when we talk about BMI, we don't really think about it or couch it as a screening test, but it's a screening tool to identify excess adiposity. It's not perfect. It doesn't distinguish between fat and lean mass or characterize body fat distribution. It's simply a screening tool to identify excess adiposity. And in this study, what they did was they looked at the 2011 to 2018 National Health and Nutrition Examination Survey, NHANES, which is this nationally representative study where they have this, big trailer that goes across the country and individuals come out and they, walk in one side and out the other, and they answer a bunch of questions and get blood tests and have all sorts of other tests done. One of the tests that was included in NHANES was DEXA scans. So in this study, they were able to go back and look at how well BMI compares to what the DEXA scan actually showed related to adiposity. And cutting to the chase, the bottom line is that BMI is a sensitive screening tool for elevated fat mass, that a BMI above the 95th percentile, for example, is 88% sensitive for excess adiposity. The accuracy of BMI changes a little bit based on what particular threshold you use, but the bottom line is it's a good screening test. It's important to consider age and sex when you interpret the BMI. For example, we know that there's a differential accumulation of fatness over time by sex. But those things are baked into how we interpret BMI already using the CDC curves, for example. So I find this study to be reassuring about the value of BMI. But we also published a commentary with the article, Body Mass Index Still Going Strong at Age 50 by Dr. Jamie Moore and Dr. Stephen Daniels, who are both at the University of Colorado Children's Hospital. One of the things I learned from this that I didn't know is that BMI actually dates back to 1832, where it was developed by a Belgian mathematician, the Quetelet Index. I probably just totally slaughtered the guy's name, but he's not around anymore to come back and get mad at me. But it was used to assess.
I feel his family will be reaching out.
Yeah, his family will be out there. But it was originally used to assess growth But it wasn't until 1972 when Dr. Ansel Keys began to promote it as a way to assess relative weight and body fatness. So it's been with us for a long time. And as this commentary clearly states, there's great value in the BMI. So this is a reassuring study.
Alex, I always find it reassuring to talk to you and learn from you, but you have left me with ABBA's Super Trooper crashing around inside my head right now.
Are we going to sing it?
So would you like to?
I would not like to. Well, actually, I would probably like to, but nobody else. Like, I don't want you to lose listeners.
So what is then? What's the song that's even more compelling? That's in your heavy rotation right now that I need to go put on right now to expunge this earworm?
Oh, so many songs. You know what I was listening to as I was coming in?
Let's hear it.
Yeah.
This is a great album if you can find it. The Roy Orbison Black and White concert that I think was recorded like 30 years ago.
Oh, wow.
With everybody who's anybody was in there, including, I think Bruce Springsteen was playing guitar in there.
Oh my gosh.
If you can find it, it's worth listening to. I think there are clips of it on this thing called YouTube you might have heard of.
All right. Well, we do not have the funds to incorporate. We cannot get licensing.
But we can do a karaoke night.
Really?
We can,
that's free.
Listen, like if I wouldn't sing ABBA, there's no way I'm going to sing Roy Orbison.
I don't know. You don't think Pretty Woman is less taxing on the voice?
I was thinking of like I'm Crying or something,
Trooper.
but
oh my gosh. Yeah, okay.
I don't think I can hit those notes.
Oh, we won't have you do it on the airwaves, but
No.
next time we get together.
To read these articles from today's show, go to aap.org/podcast.
Coming up, we'll look at new guidance on breastfeeding for people living with HIV.
As pediatricians, we always stress the benefits of breastfeeding. And I remember when I was in training, the contraindications to breastfeeding were very few, but they did include HIV.
Right, but only in well-resourced countries like the United States where formula is a safe nutritional option. In resource-limited settings, breastfeeding was still recommended even with HIV. This led to a lot of research on the safety of breastfeeding with HIV, and how we treat the virus has also changed.
For sexual transmission of the virus, being undetectable means the virus also should not be transmissible to partners. But the same is not true for breastfeeding. I know the risk is low, but how low? And what can we do to minimize that risk?
Well, let's talk about it with an expert, Dr. Lisa Abuogi, the first author on the new clinical report, Infant Feeding for Persons Living with and at Risk for HIV in the United States.
She's also an associate professor in the Department of Pediatrics at the University of Colorado and the medical director for the Children's Hospital Immunodeficiency HIV Prevention Program. Dr. Abuogi, welcome to the show.
Thanks so much for having me.
So since the 1980s, the United States has recommended against birth parents breastfeeding with HIV. What in the 2020s prompted this country to challenge those recommendations?
As you mentioned in your introduction, there's been increasing research that has showed that the risk is really quite low, and improving treatments that we know also reduce the risk. And so we felt it was time to re-examine the recommendations, as other guidelines in the United States have done, and to update this clinical report from the AAP.
The risk of transmitting HIV through breast milk still exists, even if the virus is well controlled with an undetectable viral load. So how do we quantify that risk?
So several large-scale studies have been done, most of them in lower and middle-income country settings where we pull these statistics from. And from those, we say the risk is less than 1 out of 100 women, so less than 1%. And we hope that more data will give us even better statistics so that we can talk with our patients about that.
Knowing there is this risk, why would some families choose breastfeeding in the United States over formula?
Yeah, so I think we all have talked about how, as pediatricians, we really promote that breast milk has a lot of health benefits. Those are health benefits both to the lactating parent and to the infant. And when we talk about populations with HIV in the United States, they are disproportionately affected by illnesses and conditions for which breastfeeding can be protective. So that's all going into consideration. But really, what parents tell us is what we all have heard, that they want to do what's best for their baby. They want to give the best nutrition that they can. They want to bond with their baby, and they want to fulfill their role as a parent. And most of them identify as mothers, so they want to fulfill their role as a mother. Now, some people would say, if there's any risk at all of transmitting HIV to your baby, why would you choose to breastfeed? As parents, we all make decisions every day that are not zero risk for our children. And we don't have to stigmatize an infectious disease and say that it should only be zero risk to make that decision. There are a lot of benefits, and when you weigh risks versus benefits, some families might decide that the benefits outweigh the risks.
And when a birth parent who has HIV approaches their pediatrician about breastfeeding, how should we be counseling them?
We want to approach these conversations like we would approach infant feeding conversations with any birth parent. We want to be open and offer both options if it's appropriate for that patient. We want to give them information so that they know that what the risks are and ways to protect against those risks, including taking their antiretroviral medications every day and letting their providers know if they have any challenges taking their medications or getting refills. We also want to let them know that we want to check their viral load frequently while they're lactating. So we want to check it every 1 to 2 months, and that their infant will also have frequent HIV testing as well, just to follow up both mom and baby closely.
And are there families for which a pediatrician should still not recommend breastfeeding?
Yeah, there are some difficult situations in which birth parents are newly diagnosed with HIV and haven't yet been able to get on treatment, or they've been on treatment and have struggled with their adherence, so they still have detectable viral load. There's also other social determinants of health that can sometimes make it hard to continue your antiretroviral treatment while you're lactating and breastfeeding. And for those families, we have to sometimes say, we don't recommend that you breastfeed at this time, but we're going to try and get you, to a better place.
So when you have a family that's breastfeeding with HIV, what does it look like? Are both the parent and the baby on medications?
Yeah, that's a really interesting question. So the parent definitely is on medication and has to stay on medication continuously. And unfortunately, in some states, that becomes difficult when their insurance coverage may lapse postpartum. For the infant, there's actually a lot of controversy and not a lot of consensus yet on what the infant should be on. For really low-risk infants, which these infants are low risk for a perinatal HIV transmission, sometimes we recommend just 2 weeks of infant antiretroviral prophylaxis, and some experts would say that's enough. Others would say that an extra layer of protection is really comforting for parent and provider, and so you might continue infant prophylaxis throughout the breastfeeding period. And that differs from site to site, and even our clinical report didn't give a clear guidance on that because there isn't consensus.
Should the birth parent and the baby both be seeing specialists for this?
So I would think that specialists should be involved somehow. That doesn't mean that a general pediatrician can't be the one to follow the infant to get infant HIV testing, as long as they have someone to back them up and someone they can call to answer questions. But in general, pediatric HIV experts are involved in most of these cases and are happy to support.
And let's say breastfeeding's not going well. Where should these families be looking to for support?
A really important question. We know that most birth parents who want to breastfeed in the United States don't continue it as long as they would hope and stop earlier than they had hoped. So we need to involve specialists who can help support families, including lactation specialists who are aware of these new recommendations and supportive. We don't want families to mix formula and breast milk, and we don't want them to introduce things like rice cereal early. We really want to do exclusive breastfeeding as much as we can until 6 months of age. And in cases where we can't do that, sometimes introducing donor breast milk for short periods may be possible, or consulting with a pediatric HIV expert who can help them manage difficulties in the breastfeeding.
And you mentioned this earlier, but I've always viewed breastfeeding as a public health initiative because it confers health benefits in both the infant and the lactating parent. Is counseling and supporting breastfeeding for families with HIV a move toward eliminating health inequities?
That has to be part of our agenda, especially for this patient population. And they deserve to experience those health benefits as well. So I agree with you. It's part of this decision and this changing guidelines.
We have learned so much from you today, Dr. Abuogi. Do you have any last takeaways for our listeners wanting to make sure families with HIV are well supported in their infant feeding decisions?
Yeah, providers and pediatricians can reduce stigma by introducing these conversations in an open way, the way they would to any other birthing parent, and to give great information, which we outline in this clinical report, and to say the only way that we can totally eliminate the risk of HIV transmission is through replacement feeding. But if you want to breastfeed and you're doing well in your treatment, I'm here to support you. Let's talk about it.
Dr. Lisa Abuogi, thank you so much for joining us today.
Thank you. Thanks for having me.
To read Infant Feeding for Persons Living with and at Risk for HIV in the United States, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, we just returned from Colorado where we spread Christy's stepfather's ashes at the banks of the North Platte River, but it was also a just fantastic time to see family, to visit her old home and steamboat, hike around, bike around, and just be together and enjoy some nature and some activity. So I'm kind of riding that high right now.
That's amazing. And for my Say it's positive or enlightening. So I'm going to go with enlightening. We were outside a lot this week because we were visiting the lake house that we have visited the last 15 years around the 4th of July, which is my in-laws' lake house. But this was the first year that my son got a leech.
No!
So I learned how to remove a leech.
That always comes in handy.
It was enlightening. I don't know how positive it made me feel, but I now learned something new, which I don't think I did it right. So, from what I read, but the AAP needs a new policy statement on this. There was none. Clinical report.
Back when I went to medical school, we used leeches all the time. So you should just give me a call.
What year was that, David?
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about transitioning to adulthood for youth with intellectual and developmental disabilities.
We'll speak with the lead author of a new policy statement, Dr. Renee Turchi. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.